Okay, so yeah, so I mentioned that there's going to be a change in the presentation. So as you heard someone's voice, we would, uh, Margaret, if you are on the call, I would like to start with you since you are the lady in the house, and as a protocol, they said ladies first. I actually wanted someone to kickstart with the presentation, but he just dropped out from another meeting, so he will be joining us. So Margaret, if you are there, I would like to call you to just give your opening remarks, and then I'll share your presentation if that's okay with you. Hello, Margaret. Okay. I think Margaret. Hello, Margaret. Can you hear me? Can anyone hear me?
Yeah, you are audible.
Yeah, I can hear you.
You are audible. I can hear you.
Okay. Okay. Probably Margaret is having a challenge. So if for us to be in time, then probably I would call on the regional coordinator for the Africa Network of People Who Use Drugs. Ahmed said, if you are ready, sir, the floor is yours.
Oh, okay. Thank you so much, Michael. And yeah, let me say I am joining this call a bit heavy today because of the loss of um, our champion Naomi Berkshire, former executive director of the Harm Reduction International. Um, just to state that I'm a bit broken. So if you see me not be, I'm just not myself because it's a bit devastating for us as the community and the way she contributed to harm reduction across the globe. So we are mourning, and yeah, we also ask and every one of us to join the family and to join the whole sector of harm reduction to recognize her as a champion. Yeah, so I will go to just briefly speak. As I said, my name is Ahmed Said, working with the Africa Network of People Who Use Drugs. And why we are having the existence of people who use drugs, or African Network of People Who Use Drugs, is because of the Vancouver Declaration that took place in the year 2006, 30th of April, whereby people who use drugs around the world decided to want to be empowered. They wanted to promote better understanding and experience. We wanted to be the governance of our own issue. We wanted to be recognized as equal partners in harm reduction. We wanted to be recognized as people who can contribute, not as sick people, but partners who can contribute to the sector of harm reduction and even beyond health intervention, but also politically, socially, and economically. And for this topic that I saw, it's all about involvement of people or people who use drugs or key population in programming. But sometimes we need to ask ourselves, involving from which part? Is it just involving as beneficiaries including even funding and allocation of resources. But what I really want to say in this call is that we have seen progressively how important it is to involve the people who use drugs and the key population programs. Like for instance, now I'm in Burundi, and I've seen how the Burundi Association of People Who Use Drugs are doing a very marvelous job here in terms of making sure the community are safe and service provision. They have been trusted with the likes of UNDP, and for us is just to say we are not looking for any special attention. We are just looking for equal partnership like any other partner, for us to be recognized that we are there to contribute and our contribution are valid. And we are there also to support other champions that are in this sector of harm reduction. We also encourage our member of community also to be very vigilant in terms of getting different trainings and be resilient and be in the center, because it's not enough to say you are a community member. It requires some other work for you to seem like you can contribute. And we also encourage partnership, and I am glad for West Africa Drug Policy. This year you helped us at least. We were able to form a network from Ghana, a country that has a very high interest, and we are happy that Michael and Samuel and Maria, you were able to support us to do that. And that is not over, because we still need to come back there and empower that network to ensure that Ghana is now also recognized as a network of people who use drugs. I was super happy to learn the policy that of Ghana, whereby we are having an administrative migration officer who is employed by the government, and they are using drugs, and the government has not stole their job. So for me, that was something that I really learned, and I come from a country where I know police officers who lost their jobs because they were simply using drugs. So the factor is also we need also to understand, is it the chemical that is the issue, or is it the surrounding? So ours is to try to help other stakeholders to create the better surroundings of the people who use drugs and the key population as a whole. I am glad to say that I have been privileged in my country also to serve at the country coordinating mechanism of Global Fund, where you are there and you are presenting all types of key population, sex workers, transgender, MSM, and LGBTQ community at large. And for us, even in African PWUD, we recognize the intersectionality part of it, that we are having some of us who use drugs, but we are also MSMs. We are recognizing that some of us, we are using drugs, but we are also sex workers. Some of us, we are using drugs, but we are trans people. This in a part of intersectionality. And we're just to say in this forum that for us to have a very vibrant key population-led programs, key population should be at the lead. If people who use drugs are not leading, then this program also become another form of control. But if we lead, if we are trusted, if we are resourced, then this program become very vibrant, loving, and at the end of the day with a solution-based approach. Thank you, and over to you.
Thank you very much. Thank you very much, Ahmed. That was really intensifying. And then we are great to have you as the regional coordinator for African Network of People Who Use Drugs to share your experiences. So we on the item, we actually have 5 minutes for questions. And then just to remind participants who are here that today we are discussing the inclusive of drug policy making. How has the involvement been for people who use drugs, for sex workers, and then for LGBTQI, where now we have a term to actually describe because we say people with diverse sexual orientation. Okay, James, I see your hand up. The floor is yours.
Thank you very much. Ahmed Said. My name is James. I work with the Nigerian Network of People Who Use Drugs, and I'm a founding member of the African Network of People Who Use Drugs, and former fundraising manager too of the African Network of People Who Use Drugs. So it's very great my colleague Ahmed Said is here and speaking a lot about the works African Network of People Who Use Drugs have done. Thank you very much, Ahmed Said and Watpin. So just to go in, our community of persons who use drugs, intersectional or in conjunction with the community of key population in Africa, I think we are already having this kind of a great recognition. Just as Ahmed Said has talked about, we still have challenges, and I will also mention one challenge I do see currently, despite the fact that we are making a great progress, is the disease model attached to drug use. I think it's something that we need to deculture. I don't know what to call it, destigmatize. Disease model attached to drug use. People feel that when you use drugs, irrespective of the fact that you're a drug user, you have a public health issue. That's what it looks like. But we are still, as African Network of People Who Use Drugs and other drug user networks on the African Network of People Who Use Drugs are doing well in our countries to start creating that atmosphere of dialogue to make them understand that as drug users, we are not affected by any form of disease. And this also creates a platform for us to be also meaningfully engaged. And we've been able to force that in, that if you still call us that, we want to be meaningfully engaged. So nothing without us, nothing for us without us does not mean that you just make decisions for us. No, we are there at that table making decisions in guidelines development across our African countries for drug users, in policy development, and that is really happening currently. And I would say that our visibility with the other key population is also very cordial. Virtually all key populations have now recognized drug users as a powerful force in Africa that can also contribute to the dialogue of decriminalizing key population in Africa. But despite the fact we still have little challenges, but we need to work as a movement, not working as silos, as drug users, so that at the end of the day, we can be able to decriminalize not one, but all for the future. That's our goal at the end of the day. Thank you.
All right, thank you, James. Thank you very much. Of course, nothing about us without us. That is what we are discussing here. Colleagues, the floor is open. Anyone who also have comment, questions, the floor is open. Okay, so
I go.
Ade. Okay, can you go ahead?
All right. Good morning, good afternoon to you all. So my name is Joseph Lawrence Hammond, and I'm the executive director at Empowerability Organization. So we provide innovative training and capacity building programs for differently abled persons, that's the youth with disability, to be precise. And our main mission is to unlock the potential of youth with disability, breaking down barriers and creating inclusive opportunity in agriculture, climate change, and sexual and reproductive health. Leveraging on technology, so our main is to leverage on technology innovations and what have you. Thank you very much for this opportunity. And I think it's really a nice topic to be to be discussed at this moment. I have just 2 questions for now. Talking about this key component, I would like to ask, can you share examples of successful inclusive decision-making initiatives that have improved outcomes for youth with disability? I'm just trying to, come in from where I work. So, talking about persons with disability, what are some of the challenges? Can you share some of the some examples of successful inclusion or inclusive decision making initiatives that have improved outcomes for youth with disability? And the second one, how can we address this intersecting stigmas? I think that the gentleman that just spoke talked about stigmatization. So just stressing on that, how can we address the intersecting stigmas and barriers faced by youth with disability who are also PWUD, sex workers, and what have you? Thank you very much.
All right, thank you very much, Joseph, for your comment and your question. Ahmed, would you like to address the latter part? So I'm sure the first question would have to do still link to people with disability who use drugs. One way or the other, there's that kind of connection. So Ahmed, I don't know if you have anything to say.
Yeah. So very, very quickly, I think it's an ongoing thought-provoking conversation based on what the first comment from James, like, until we talk about HIV or hepatitis or TB is when now the people who use drugs conversation comes in. It's the same thing. And people, most of the allocation that we have right now, they haven't recognizing the intersectional part of it, because we are having people who use drugs with disability based on as a result of violence from general population. We are having people who use drugs with disability as a result of just they were born like that, So it's a really thought-provoking conversation that we are trying to table it. However, not very many partners have been open to support the intersectionality, because one of the things that we are trying to say here is, what if we didn't have HIV? For example, if we were not living with HIV, would people who use drugs come to conversation, or will sex workers come to conversation? But you find the main tag that we are having is the disease tag of it, and we are trying to fight that whenever you think about key population, don't only think about condom, ARV, and needle and syringe, but also think about other avenue like empowerment. We need to meet other ministry, not only the Ministry of Security. And so what we are trying to avoid here is the criminalization and the pathologization, because you are either a sick person or you are either a criminal. If you are not sick, if you are not a criminal, you are a sick person. So that is the notion that we are trying to fight. However, we highly recognize that all our channel of interventions are addressed under HIV. And I think it's a conversation that might take some time, but at least a few are listening. We know the likes of Love Alliance, who have been very, very open. Unfortunately, they are going out this year. So we know the likes of Robert Carr, who are there willingly to support this initiative, but they are also struggling with finance. So we really need to repackage, I think, our message and see how do we deliver it in a way that it's clear, with clarity, and at the end of the day, something that can be substantive to be supported in terms of resources. Over.
All right. Thank you. Thank you very much. Thank you very much. I think I'll just take one more question if there is any. If there is no question, okay. Margaret, if you are ready, let me know so that we move straight to your presentation.
Hi, everyone. Good morning.
Okay. Okay. I just want to be sure if you are there. So probably let me just do the introduction again. So everyone, Margaret is a barrister and a solicitor at the High Court of Sierra Leone. She is here to present the legal aspect, or probably looking at it from the legal angle, where we talk about inclusive decision making. How are we involving marginalized people? So over to you, Margaret. Let me just share your PowerPoint presentation, if that's okay with you. Okay, Margaret, the floor is yours.
Thank you very much. I am so sorry I disappeared the first time you called me. The minute you mentioned my name, the electricity supply system took power, so I had to find an alternative to be able to be connected again. Good morning, everybody. Again, my name is Margaret Enin. My presentation is quite a journey. I mean, it will take some time, exactly 15 minutes prescribed by West African Drug Policy. So please hang on. This is a photo of Abuja area mama. He was a sex worker, a gay man, and of course, he was very proud of it. In August 2024, Abuja area mama was killed. He was beaten to death and his body was disposed of in an express highway in Abuja. You know, I followed the investigation for quite some time, and the chief of police in his investigation stated that the investigation is quite a thorough and discreet one. And then I looked at it and I said, I mean, what would I expect? What would any other person expect from the general populace when the senator of that particular country, one of the senators who is seen as a custodian of national interest, introduces death penalty for drug traffic offenses? So what would you expect from the general populace if a senator introduces death penalty for just drug traffic offenses? Michael, can we please take the next slide? So in my presentation, I'll be examining how lawyers and the Bar Association can support this movement by using their legal expertise, systemic advocacy, and of course, emphasizing the challenges posed by discriminatory laws. At the end of this presentation, I would want you to understand the impact of discriminatory laws on marginalized communities and the role us as legal professionals can play in empowering their efforts. Next slide. So my topic is Beyond the Courtroom, how lawyers and Bar Association can support community-led human rights movement. So I'll be looking at Sierra Leone, Ghana, and Nigeria. Thank you, Michael. When lawmakers are enacting certain laws. Sorry.
Hello, Margaret.
Yes.
Okay, so there's an interpretation So if you can kindly slow down for the interpreters to get it, for our French audience to also follow what you are presenting. Thank you.
Okay. So when lawmakers are enacting certain laws, they take multiple factors into consideration. Factors like public safety, morality in certain countries, healthcare, to name but a few. And some of these laws have been dressed as protection laws. But then the question is, who are these laws really protecting when most of these protection laws tend to police poor people? These laws tend to harass marginalized groups. Let's look at Section 7 of the Public Order Act of Sierra Leone, the Public Order Act of 1965. This particular act is one that is vastly used by police officers in Sierra Leone. In fact, any single police officer in Sierra Leone can reiterate this particular section with their full chest, because this section has been used to harass sex workers. It has been used to exploit them. This section provides for a police officer to arrest any person that is found on the streets in the middle of the night without giving any reasonable reason as to why you are on that particular street. So this particular section has been used as a tool for harassment. It has been used as a tool for harassing sex workers and many other Sierra Leoneans, as the case may be. The same thing applies to the Same-Sex Marriage Prohibition Act of Nigeria. This particular act criminalizes love. It's funny, but this particular act criminalizes love, and it criminalizes this particular act, as I was saying, criminalizes love. How would you tell a certain person who to date, who not to date, or what to do, or what not to do, or who they choose to be, or who not to choose to be? Can we please move to the next slide? So the impact of this particular law has been tremendous. The impacts that these lawmakers have made when making these acclaimed protection laws have been tremendous. In their minds, they think they are controlling crime, but in reality, this has been crisis. It has been a whole bunch of crisis creation, because look, here in Sierra Leone currently, 63% of cases at the Kisi Psychiatric Hospital is linked to kush addiction. This is because they have decided to criminalize drug use instead of manage and tell people exactly how to use them. Look at Nigeria. The National Drug Law Enforcement Agency reported in 2023 that 40% of violent crimes in Nigeria have been linked to drug use. If you come to Sierra Leone, 30% of sex workers under the age of 18 are being trafficked. It's funny how these people do not even know the amount of girls that are into hookup, because for a second, if you know the amount of girls that are into hookup, you would particularly legalize sex work, because this will give them a reason to be able to manage it and know exactly and also notify these people how to live and what to do exactly. Michael, can we please move to the next slide? Hello. Thank you very much. Thank you. Thank you very much. This is exactly why lawyers need grassroots movements in ensuring equality and active participation. Grassroots movement, these particular people carry the raw and unfiltered experience that can be found in no policy paper or no legal brief. These people carry lived experiences. These are the sets of people that protect victims and ensure case participation for lawyers. These particular people ensure that they expose systemic abuse and any gap that is in any legal framework that causes inequality, and of course that does not ensure active participation. Michael, can we please move to the next slide? I am so sorry, it's taking a bit slow. So having seen how criminalization perpetuates harm, this is where lawyers become agents of change, not just in the courtroom, but to work side by side and serve as powerful allies to grassroots movements, to challenge discriminatory laws. One of the things that lawyers can do in order to ensure that the voices of marginalized groups are being heard is to challenge discriminatory laws, policies, and of course practices. I remember there was this one article that was posted by a senior colleague at the bar here in Sierra Leone, Michael ESQ. I mean, he said the government is supposed to, in fact, the government must decriminalize petty offenses like loitering, as I mentioned earlier, in the public order offenses here in Sierra Leone. And also, the BAC can provide legal education and awareness for grassroots movements. They can advocate for legislators to draft inclusive laws with active participation of marginalized groups. I mean, they can advise these communities on how to document and also tell them about protection mechanisms. Can we please move to the next slide? Thank you very much. So while individual lawyers are important, systemic change actually requires collective action. This brings us to the role of the Bar Association. If you look at Section 1, subsection 3, paragraph K of Nigerian Bar Association Constitution, it provides that the bar should serve as a watchdog. I mean, this is one of their objectives. The bar should serve as a watchdog to of the rule of law. This is to ensure that every individual lives equally, and of course they have equal access to their fundamental human rights. So what the Bar Association can do is to collaborate with Council of Legal Education. I mean, if you look at some of our law schools, I remember I saw this one article where the West African drug policy said 70% of lawyers in West Africa lack the basic human rights knowledge, human rights training. And of course, this is true. So what the Bar Association should do is to collaborate with Council of Legal Education to integrate foundational human rights modules into law school. So every single lawyer that is coming up will have an opportunity to be grounded in human rights, to be grounded in human rights training. They can also partner with grassroots movements to challenge systemic justice. Like, for instance, the AVOC-AID in Sierra Leone. AVOC-AID partners with lawyers in order to ensure that sex workers have a place. And of course, if they are arrested at night, they are being able to go back to their home and of course, proceed with what they're doing. I currently serve as a duty counsel for the lawyers. I mean, it's an association of female lawyers here in Sierra Leone. So what we do is we work with AVOC-AID directly, and the project that I am working on, we ensure that sex workers are safe. And also lawyers can encourage, I mean, the Bar Association can encourage lawyers to offer pro bono services. This is something that is very difficult for most lawyers because a lot of people are not really interested in human rights, anything that concerns human rights. So the Bar Association can encourage lawyers to offer pro bono services, lobby for policy changes to lawmakers in order to ensure that they create a safe space for marginalized groups. Michael, can we please move to the next session? So I was looking at some things that can be integrated in order to make sure that we actually have a community of people that are being represented, and of course having them being included in this particular decision making. So lawyers must go beyond legal representation. See, our traditional legal role is to serve in courtrooms. And of course, what we can do in order to ensure that these people are safe is to act as educators. We tell them exactly what the law is. We act as protectors. If a person is being arrested, for instance, if a gay person is a member of the LGBTQ community is being arrested, I can go to the police station and find ways in order to get the person to move out. And of course, Bar Association must integrate human rights priorities into legal trainings and public outreach programs to advance inclusive justice. Outdated weaponized protection laws must be replaced by inclusive decisions that actively safeguard the rights and dignity of marginalized community. Currently, our society is progressively retrogressing. I would say this for fun fact. Most of the laws that are in existence in West Africa are colonial era laws. And these laws, maybe at the time they were in existence, they were meant to protect people, but because of how the society is moving, because of how the society is currently going, these laws tend to be weaponized protection laws. So if we can be able to get rid of these laws, to repeal and replace them, and have marginalized people on board to tell us exactly what is going on with them, then we can be able to draft laws that cater for their rights and also make sure they live in a complete safe environment and have access also to their fundamental human rights. Michael. Okay, thank you
Yeah.
very much. Ladies and gentlemen, as I was saying, we have a responsibility. It's either we all be allies or we be a cog in the machine. I must note, the law does not change on its own. Every single day you watch, new laws are being implemented, new laws are being passed. The law does not change on its own. It requires us to demand more. I mean, the first slide I showed you, Area Mama. Yesterday, August 2024, it was Area Mama. Tomorrow, it might be me because I might wake up tomorrow and decide, okay, I'm not comfortable with who I am. I probably want to get out of the closet. I probably want to do some other things and all of that. Tomorrow, it might be you. So let's work together to create a safe space that enhances participation. Thank you very much. I am open to any questions from anybody.
Thank you. Thank you very much, Margaret. I mean, let's all come together to kind of create a safe space for everyone. That was really a powerful presentation. And thank you very much for sharing this from the legal angle. The floor is open to participants. If you have any questions, any comments, the floor is open. Thank you very much, Margaret, for this wonderful presentation.
You're welcome. I would have showed you my pretty face, but there's currently no electricity.
Okay, all right. So colleagues, if anyone has question, the floor is yours before we go on to our next presentation. Okay, James, your hand is up. Please, the floor is yours.
Thank you very much for the great presentation, Ma. I'm so happy about the word you talked about, protective. I just want to get a phrase for it. Protective, weaponized protective laws. I think that's what we are battling with as key population members and a key population member in their diversities in Africa or West Africa. Let's use West Africa as a case study. But I just want to ask, I come from Nigeria, so I know what happened with Area Mama and also the rest. So questions I want to pose is, do we have opportunities for funding for community-based key population organizations to apply to? Because I found out that most of our fundings are more tilted into HIV, TB, hepatitis. I think we have lesser funding on human rights. And the more funding we have on human rights is mainly for the LGBT. I don't know if I stand to be corrected. I think the LGBT community is the only one that have more of human rights funding in West Africa. And we've been having a little bit of challenges working with this movement building thing, because mostly the funding that come in Nigeria to LGBT, they don't include drug users or sex workers. More of it don't include. And that's why a lot of communities are still left behind. Some are not even doing well because they are not working as a movement. How do you think we can be able to, or what opportunities are available for key population organizations in their diversity tap into paralegal education, and also how to start developing policy challenging? How do we develop our skills in challenging policies at the end of the day? And also digital protection of our work. Thank you very much. What opportunities are available?
Sorry, can you please repeat your question? The first one, I didn't get it. How do we develop?
Okay, so what opportunities are available for key population organization, marginalized groups, you understand, to be able to tap into funding? What funding opportunities are available for us to be able to apply to be able to get more funding? Because most of our funding are more of disease-based funding, not human right-based funding. What funding opportunities are available for key population to tap into to be able to build our structures, to be able to challenge policies in our various countries?
What funding opportunities are available?
Yes.
I honestly wouldn't really know what funding opportunities are available, because me myself, I am a lawyer. I work with marginalized groups, so I believe they have donors. that fund them. For me, I do pro bono services when it comes to helping these particular groups. So I don't really know where they get their fundings from or how they will be able to get funding and all of that. Because for me, they just report cases to me. Like, for instance, you tell me a sex worker is in a police station, and then I'll make myself available to try to bail the person out and get the person to go back to exactly what they were doing. So I don't really know where they get their fundings from or how you can get your fundings or anything.
Just to add to it, that's why I was asking, maybe it's for the house generally, because we noticed that funding is always available to the LGBT community. For drug users, for sex workers, human rights-based funding is very scarce or rarely not available. And that is why we see a lot of violence affecting drug users, sex workers, maybe compared to LGBT, but I know it's almost the same. But sometimes I challenge LGBT organizations in West Africa to start seeing how they can embrace their funding to cover other key population in their diversity, because there's a case that happened in Lagos, a case of a gay party, and they knew they could not challenge the LGBT guys, maybe because they were backed by the US government and the rest. But they find a clause to be able to arrest the LGBT guys. And what clause do they use? Drug use. Oh, there was drugs in the party, there was cocaine, crack, and methamphetamine in the party where they were in the gay club. So that is why they arrested them. So sometimes to also challenge these communities that have much more funding, to also embrace other key population members in order for us to build that movement, because mostly their funding is always one-sided, only to their community, but not to extend to other key population communities, so that we all can build our skills together to collectively challenge policy. That's one question I'm bringing out to the house here. How do we start creating that advocacy platform within our communities and donors?
Okay, thank you, James. I think Prince and Jerome has their hands up. So Prince, probably you can just open your mic and then Jerome will come after.
Yeah, thank you very much, Michael. And I hope my voice is clear. Yeah, so James, that was a good question, and I also appreciate Margaret's response to that, because it's unlikely that she may have worked in the in the sector right now, but also James, yourself, you've provided some answers to your questions. But what I wanted to add to what you said was, or draw your attention to, I mean, for all of us, or most of us who are here who rely on funding from donor partners, we definitely understand the landscape. So I wanted to add that so donors have been before now, I mean, before the Trump era and halt and pause on all of the fundings to the South, donors have tried to encourage intersectionality. They've tried to foster collaboration between, I mean, different vulnerable groups or minority groups. So you and I know that for most harm reduction or key population fundings have been tagged, like you said, under the HIV programs. So they have encouraged organizations to leverage on intersectionality. So whether it's persons with disability who use drugs, whether it's commercial sex workers or male sex workers who use drugs, men having sex with men who use drugs, key population, but then trying to intersect and explore that venue. I mean, I'll be speaking later, but then also letting you know that this webinar is as a result of that, because
good day, my people.
It seeks to address.
Well, are you okay?
It seeks to address or try to bring recognition to three main categories of or three main communities: people who use drugs, sex workers, and the LGBTQ community. But like you said, most of the fundings come for LGBTQ. So it's spread among the different communities. So my contribution to your question is the focus: how do we attract funding. Probably if we try to focus more on intersectionality, it will help attract the fund, whether it's for human rights, whether it's for public health and the like of it. Thank you.
Okay, thank you, Prince. So we'll take the last comment from Jerome, then we'll move to the next presentation. Hello, Jerome, the floor is yours.
Thank you. I am Jerome from Ivory Coast. Thank you, WRDPN, and thank you for the presentation. It's not a question, it's more a remark. For me, it's not only a human rights issue. If we talk about intersectionality, we need to talk about money. We need to talk about poverty. For example, a rich drug user, a VIP sex worker that don't work on the street, a rich LGBT don't have so many issues with law because we have access to lawyer, we can make corruption, we consume or we make sex in a safe place. So I think it's important to talk about this too. It's more a war against poor people in reality than a war against us. For me,
thank you.
My opinion.
Thank you. Thank you very much, Jerome. Thank you for that wonderful submission. So in the absence of any other questions or comments, we would jump straight to the next presentation by Samuel Hanu. Hello, if you're on the call.
Yeah, I'm here. Can you hear me?
Okay, yes, super. I can hear you. So if I have to just put your presentation up, if that's okay by you.
Okay, that's fine.
Okay. A minute. Okay. The floor is yours now.
Yeah, hello. So good afternoon here. Good afternoon to all of you, and good afternoon to my other speakers. So I'm speaking on promoting a person-centered, recovery-oriented, and human rights-based approaches in substance use management. Next slide, please. Hello. Yes. So yeah. So that's the outline of my presentation. I'll talk about the social determinants of health. We'll explain about some key terminologies. What is human right based? What is person-centered care? What is legal capacity? Please enter.
All right.
Or I guess the network. So I want to thank my other speakers. I want to thank Ahmed Chiab. Yes, we'll lose some people along the way, but we'll not lose the fight. We'll keep on fighting. So Chiab, smile. Next slide, please.
All right.
Next slide, yeah. So
just forgive me.
yeah, so this is the objective of the presentation. You can just go on, please. Just go on. The objective of the presentation. So because of time factor, so can you do the next slide, please? Yes, I want to start by talking about an experiment that was done some years back in the US. It is called the rat pack experiment. So the experiment compared two groups of rats. One group lived in a standard barren cage where there's no much fun, there's nothing, just the normal cage that they were in. And the others were put in a pack they called the rat pack, which was more larger, more spacious, more stimulating. It had a lot of toys, a lot of social interactions, you know. So the second pack was more like an enriched pack compared to the first one, which was just a normal pack. I mean, just hit again, please. So the key, both groups had access to water and food. but the water in both cages were laced with drug, which was an opiate. And what we're trying to measure is the amount of drug that the rats consumed by the end of the day. Next slide, please. And what was the results? The results show that the rats in the enriched rat park environment chose the drug-laced water less often than the rats in the standard cages. This indicated that the rats in the more enriched environment were less likely to become addicted to the drugs. So what we have to be aware is that here, the rat may have the biological determinants to have addiction, but the social components were very profound. So let's look at the significance. The rat park experiment demonstrated the significance of social context and environmental factors in addiction, suggesting that reducing environmental stress and increasing social interaction could be important interventions in treating addiction. So I heard one colleague of said that it looks like we are using this, we looking at so much on, we focusing so much on this, the medical model. We have medicalized addiction, you know, but this research is showing that despite the biological predisposition, the social context is also so very important. So next slide, please. So I want to just build a bit about the social determinants of health. So first of all, next slide. So the first thing we don't want to talk about is the demographic domain. So we talk about age. What we know is that during childbirth or when a woman is pregnant, the first 2 years of pregnancy is very, we are moving too fast. Backwards, please. The first 2 years of pregnancy is very important. We also know that drug use begins in young age, you know, and progress. When it comes to sex, we also know that men are more likely to use drugs as compared to women. We also know that even though the rate of depression is 2 times more in women than in men, and depression is the main reason why people commit suicide, more men will die by suicide by women. We also know that ethnicity is also, a lot of people are facing, because of their ethnicity, they are having, next slide please, they are facing discrimination and other things. Then we talk about the next slide, the economic domain. And we also know that income is also a determinant, a risk factor, you know, people who are having issues. Next slide. People who are having poor income or are not having income at all, people who are having food security issues, people who are having employment issues. Okay, just go ahead. Next slide. Then we also talk about the other domain. Let's go. Next slide. Yeah, so the neighborhood domain. So we talk about, let it remain here for some time. So we talk about the built environment, very critical. How is the environment looking like? What about water and sanitation? For those of us in Ghana now, we are talking about galamsey. People are having their water bodies contaminated. It's also an issue. People are having issues with housing. People are homeless. You know, community infrastructure. How is the community developed? Is it all about cutting down trees and building cement blocks, or having the way we design it? These are all issues that affect our social determinants of your next slide, please. Next slide. No, I mean heat. Yes, heat. Yeah, so we're talking about heat, just heat. Enter. Yeah, so the environmental events. So we're also talking about exposure to violence. In other places where there's war, we know what is happening, natural disasters. Recently in Ghana, there were floods, people have died, there's war, there are other issues. This also becomes a problem. So these are also social determinants of health. Next, heat, please. Enter. So we also want to talk about next slide. Yes, next slide. Yes. So the sociocultural, let it remain here, please. So the sociocultural factors. And we talk about social capital when it comes to addiction. When we talk about social capital, we talk about the resources the person has to go through their recovery. Do they have the resource, the support that they need? What about social stability? What about culture? You know, how's the culture like? Do they support addiction, or is it full of stigma? I mean, culture here. I also want to talk about critical thing. I mean, in this part of our world, a child is born and a grandmother comes in and say that they want to massage the the head of the child with hot water, you know, and as even the woman that is putting her hand in the water she's feeling the hotness of the water, and is trying to massage the young baby. I mean, 1 month, I mean, very tender age baby. You are cooking the brain. Can you imagine? They also talk about social support, and one critical important thing, good quality education is also a protective factor, because if the person is having good quality education, the person is able to go to school, and the person is following and understanding, the person will remain in school, the probability that the person will go to other deviant behavior is less. I mean, or we can delay the drug use of the person as much as possible, so the person will not start using drug at a tender age, you know. So these are all next slide, please. For them, social determinants of health. I've decided to spend some time on these social determinants of health because of the experiment that we spoke about, the rat pack experiment, which says that the social determinants of health are more critical, and if there's any intervention, we need to look at that area. So, Mike, it looks like you're going too fast. Okay, so we'll talk about disability. What does disability mean? According to the United Nations Convention on the Rights of Persons with Disabilities, disability results from the interaction between individuals with impairments or health conditions or social barriers that limit their full and equal participation in society. That's disability according to the CRPD. Next slide, please. Then we also talk about what is psychosocial disability. Next slide. So this refers to the barriers, for example, discrimination, stigma, and exclusion that arise from the interaction between individuals with mental health difficulties and attitudinal challenges, and environmental factors that hinder people's full and equal participation in society. Hit again, let's see. So that's how we define psychosocial disability. And the keywords here are what? Discrimination, stigma. Then what do we mean by persons with disability? Persons with disabilities are those with long-term physical, mental, intellectual, or sensory impairments that, when combined with barriers, hinder their full and effective participation in society. Are we okay? So we turn this disability, persons with disability, psychosocial disability. Next slide, please. Then we talk about what is community mental health care. So I made community mental health care because in this part of our world, the substance use treatment services are really not completely developed on their own, and sometimes they are embedded into mental health care. And when you look at it, the whole definition, now the focus of mental health care is about community care. We want to encourage that. We want to encourage more people to have the services in their community. So what does community mental health care involves? It involves a network of interconnected services, including mental health services, integrated into general health care. So the person should be able to go to a general hospital and have his addiction or substance use screening done, so that the stigma will not be there. Then we also talk about community mental health centers, outreach services, providing care at home or in public spaces, and access to key social and other support services, very critical. Access to key social and other support services like access to accommodation, access to legal services, and all that. Next slide, please. Then when we talk about lived experience, what does it mean? This can refer to personal experience with mental health services, mental health conditions, or addictions, or specific living conditions like poverty. It describes how someone has experienced or understands a particular situation, challenge, or health issue. Now it has come to us that people with lived experience have unique experiences that we cannot do anything without leaving them out. In fact, they are experts on their own, and they bring a whole experience on the board. We can't do without them, because some of us, we are here because of our expertise, because of our knowledge and all that. But that cannot be alone. We can't work alone. We need to work with people with the lived experience of that specific condition, so that we can hear their perspective. Next slide, please. So human rights-based approach. What is human rights-based approach? So when we talk about human rights-based approach, this is an approach grounded in international human rights law, aimed at promoting and protecting and upholding the human rights of individuals in mental health and, by extension, drug use services. It involves adopting legal and policy frameworks that comply with state obligations and international law. It equips both state and non-state actors to identify, critical. Let's identify. Let's pay attention to this. Identify, analyze, and address inequalities and discrimination, and to reach those who are marginalized. So it's not only on the state, but it also involves all of us to identify, analyze, and address inequalities and discrimination, and to reach those who are marginalized. Next slide. It also provides avenues for us to be able to have redress when people have suffered from human rights abuse. So what is person-centered care? This focuses on aligning the care that we give to people with the individual's preferences. What are the individual's preferences? Their needs, their values and strengths, and with people's unique circumstances and goals in life. So as somebody who's a youth counselor, one of the things we were taught is that when you're counseling somebody, you have to meet the person where the person is, not where you are, but where the person is. It requires that people actively participate in decisions about their treatment and care, aiming to foster trusting partnership, dignity, respect, and autonomy, while also addressing social and structural factors affecting mental health to provide holistic care. Please, it's okay. Then we want to talk about some critical areas of human rights. We want to talk about respect for legal capacity. So the CRPD defines legal capacity as the capacity to be both a holder of rights and an actor under the law. Legal capacity to act under the law recognizes the person as an agent with the power to engage in transactions and to create, modify, or to end legal relationships. All of us, irrespective of our health conditions, have this legal capacity. Next slide, please. The right to make decisions for oneself and to have those decisions respected by others. So that's when we talk about legal capacity. Promoting people's autonomy is critical for their mental well-being. And it's also a legal requirement under international law, particularly the CRPD. Next slide, please. They also want to talk about something that normally happens. When you heard about the word substitution decision-making, this refers to regimes where a person's legal capacity is removed and a substitute decision-maker is appointed to make decisions on their behalf, often based on what is perceived as the person's best interest rather than, please hit it again, enter. Rather than what the preference of the person. And this we don't want in our services. We don't want people to be practicing substitute decision-making by we appointing people to make decisions. It's like when a person is not in the right frame of mind to make their own decision. Please, next slide. So we are talking about supported decisions. So we want to move from substituted decision-making to supported decision-making. And what does it involve? Well, it involves the appointment of a trusted person or network of people who can provide support in weighing up different options and decisions by the person concerned. 2, advanced plans. So advanced plans is like, advanced plans comprise statements concerning people's will and preferences in terms of the care and support they receive. They receive among other matters. So here the person writes something down so that in case I suffer from dementia, which is a neurological mental condition that affects old age, or for one or two reasons, I'm not in a position to take decisions, please, you can take me to this hospital. I don't want you to talk to this person. My insurance is at this person. I want this person to do this for me. So advanced directives, so plans, we made it and put it down. So in times when a person is not able to make those decisions, everybody knows that this is the decision the person has made, that in times when he cannot make those decisions, these are what is supposed to be followed. Or we can even appoint, just like you said, the first one, appointment of a trusted person or network of people who can provide support by weighing up the options and making a decision. But this one, the person who is involved, who appoints them, and not another person appointing them to make the decision on their behalf. Next slide. So non-coercive practices. So what is coercive practice? Coercive practices refer to the use of forceful persuasion, threats, or compulsion to get a person to do something against their will. And we see this in some of our facilities. We are saying that we are bringing this to the attention of especially people who are in the drug addiction or drug management business because of the abuses that has gone on in the mental health institutionalized facilities. Some places they are closing these ones down. But there's no way, I mean, when it comes to drug use, sometimes you have to put people in institutions, and those institutions must be aware about some of these practices that are not, do not comply with international laws. We talk about non-coercive practices, where we said that it's what we refer to the use of forceful persuasion, threats, or compulsion to get a person to do something against their will or their wish. In this way, coercive practices also involve the denial of people's rights to exercise their legal capacity. So some examples of coercive practices include involuntary admission, involuntary treatment, or the use of seclusion and of physical, mechanical, or chemical restraints. The right to liberty and security of a person in the CRPD underscores actions to address coercion by providing by prohibiting the deprivation of liberty based on a person's disability. We don't see that the person lacks insight, or the person is a danger to himself, or the person, so because of that, will forcefully tie the person and move the person to say that the person should go for treatment. It doesn't. No, it doesn't. It's not right. So that is coercive practices, and it is against international law. Good. So let's go on. Non-coercive practices. It also includes freedom from torture, freedom from cruel, inhumane, or degrading treatment, punishment. We should not punish people because they've come for treatment. Freedom from exploitation, violence, and abuse, forced admission and treatment. These are all coercive practices. Forced admission, please enter again. So this all falls under seclusion and restraint. Administration of antipsychotic medication. So the last three, the 6, 7, 8. We cannot do it without the consent. Please hit again, enter. Without the consent of the, no, so there is the 7, 8, and the 9. So the administration of antipsychotic medication, electroconvulsive therapy, psychosurgery without informed consent. I mean, all these three, we can't do it in a hospital without the patient consent. So when you go to the hospitals, when they're going to give you a ECT, they give you give a consent. Admission, I mean, when they're going to give you antipsychotic medications, you know, sometimes you need to administer antipsychotic medication to some of our patients. We must all realize that we cannot do these things forcefully. You have to get the consent of the patient before we, next slide, please. I know my time is, yeah. So, yes, enter. So we'll talk about participation. What do we mean by participation? People with lived experience, due to their own knowledge and experience in the area, have an important contribution to make and a central role to play in the design. So just take notes in the design, not that we design it, come and implement it to them and tell them that they should come. We have designed it, so they should come and come and help us to implement. They must be involved in the design of the project, whatever it is. In the development, in the implementation, in improvement, in transformation, and even the evaluation of it. They must be involved, because nothing for us without us. So once we are doing it for them, they must be involved in every step of the way of mental health service, as well as in supporting and delivering direct services to others, such as peer specialists. So they not only get involved, but they can also play the role as what? Peer specialists, peer support, and peer-run crisis service, because they know it best. And when we talk about peer, it's very important, because when we talk about peer, sometimes, for instance, adolescents, we know that adolescents suffer mostly from what? Peer pressure. But what research says is that it's true they suffer from peer pressure because they value the comments or suggestions or views of their peers more than sometimes their parents. So that's how come that peer support system is very critical in helping people, and people who have that lead experience or who are experts on their own. Next slide are the people who are best to do these things. Then community inclusion. What do we mean by community inclusion? Providing people with a range of in-home supported living and other community support services, including personal assistance necessary to support living and inclusion in the community, and to prevent isolation or segregation in the community. In terms of crisis, it's especially necessary for mental health services to respect and fulfill the right to live independently in the community. So people who are going through recovery, they have the right to live independently in the community by providing support according to the person's will and preferences. So if they say that I don't want to stay in this area, or I don't want to stay with this relative because of, it must be respected because they have genuine reasons for saying that, where they are comfortable, where in their own home or with friends or family or mental health setting or other mutually agreeable location, mutually agreeable, not where we, the professionals, think that they need to live. No, it should be mutually agreed location. Next slide, please. So we also talk about the recovery approach. So when we talk about the recovery approach, we focus on supporting people to regain and maintain control over their lives. Recovery is personal. Everybody is personal to everybody and different for each person, and can include finding, for some, recovery means finding meaning and purpose in life. For some, living a self-directed life. For some, strengthening self-worth, healing from trauma, and having hope for the future. Each person defines what recovery means for them and decides which areas of life to focus on as part of their recovery journey. Next slide. So recovery means that the recovery views the person and their context as a whole, rather than aiming for the absence of symptoms or so-called cure. So I'm saying that, yeah, okay. So I'm saying that some of our drug rehabilitation facilities, somebody comes for the rehab and the person goes out to drink alcohol. And the person comes back and they say that, no, we are sacking you because you've gone out to drink alcohol. It's not right. I mean, the person is struggling. If the person is able to stay off from the alcohol or from the drug, the person will not come to the facility. They are struggling with it. So please help them, support them, meet them where they are, and help them to go to. Next slide, please. So from here, we want to talk about some principles because of time factor. So principles of recovery oriented service. So you talk about connectedness, which means this principle means that people need to be included in their community on an equal basis with all other people. This may involve developing new meaningful relationships, connecting with family and friends, connecting with peer support groups and other groups in the community. Next slide, please. So the next principle is about hope and optimism. Although hope is defined differently by different people, the essence of hope is the affirmation that living a full life in the presence or absence of symptoms is possible. Please hit again. It also implies the belief that one's circumstance can change and or that one will be able to manage or overcome a situation. Next slide, please. Then the next principle after the hope and optimism, the next slide, please. Then we also talk about identity. So the recovery approach can support people to appreciate who they are, strengthen their sense of self and self-worth, and to overcome stigma, external prejudices, as well as self-oppression and self-stigma. It is based on respect for people and their unique identity and capacity for self-determination, and acknowledges that people themselves are the experts on their own lives. They are experts. So as health workers, I mean, if you're a health worker here or something, bear in mind that when you're helping people, they are the experts. They have gone through, they have peculiar experiences. We are not the experts, even though we are professionals. They are the experts. It is not just about personal identity, but also about ethnic and cultural identity. Next slide, please. So finding meaning and purpose in life. So recovery supports people in rebuilding their lives and gaining or regaining meaning and purpose according to their own choices and preferences. Very critical. Their own choices and preferences. As such, it involves the respect for forms of healing that can go beyond biomedical, psychological interventions. Yes, next slide. So I'm almost about ending. So we talk about empowerment. So empowerment has to do with the heart, is at the heart of recovery approach. And so these are my, so empowerment has been at the heart of the recovery approach since its origin, and posits that control and choice, CC, is central to a person's recovery and is intrinsically tied to legal capacity. Next slide, please. So for those of you who want to hit again, enter. There's this resource that you can go on and learn about supported decision-making, legal capacity. So you can, it's online. So these are my references. So thank you very much. If there are any questions, so just hit, enter. About two slides for reference. But if there are any questions, I'm here to address them. Thank you very much for your attention.
Thank you very much. So I think looking at how detailed the presentation is, we'll be sharing it. Colleagues have been asking if we are going to share, so we'll be sharing it. Thank you very much, Mr. Anu, for this wonderful presentation. I know we are far behind time. We need to just do it and then wrap it up. But I'll still leave the floor for one or two questions or probably comments, and then we can move to the next presentation, which is the last one. Then we can call it a day. Thank you. Okay, so let me check the comment section if there are any questions over there. Okay, I think James was asking if we are going to share. Yes, I've answered that. And okay. So in the absence of any comment, questions, I think we'll just have to move to the next speaker. Okay, there's a hand up. Okay, please go ahead.
Okay.
Go ahead, please. Okay, I think the network is not, because I can't hear. Okay, Prince, if you're on the, yes. So Prince, if you are on the call, probably maybe we can just take your submission and then we do a final round. If there are any questions and comments, then we can call it a day. So Prince, the floor is yours.
Thank you very much, Michael, and good afternoon, everyone. My name is Prince Bull, and I want to thank my colleagues who have made their interventions before me. I do not have a PowerPoint presentation, and I hope not to stay any much longer. Like Michael have said, we have taken much time. I want to provide a background to why we are probably here, and how it connects with the concept of nothing for us without us. The West Africa Drug Policy Network is working alongside with other organizations, diverse organizations that focuses on people who use drugs, sex workers, as well as the LGBTQ community. With regards to nothing for us without us, the West Africa Drug Policy Network over the years have tried to adopt and also integrate that program into our interventions. We have made sure that since it was an organization that focused on policy reform and people who use drugs, we have ensured that most of our programs started with people who use drugs, their participation, their representation, and their involvement. The current project we are running has to do with the recognition of these three communities: people who use drugs, the LGBTQ community, and sex workers. The inclusion and recognition in decision-making at the regional level. So the presentations my colleagues have made earlier on support that initiative. So we went about engaging all three of these communities in Ghana, in Burkina Faso. These are areas the project covers: Burkina Faso and Nigeria. So we had to bring people of this community into the same room and ask their perspective. I think the important part of nothing for us without us is because, like the last speaker just said, in the aspect of recovery, everybody recovers differently. He spoke about drugs. So for you to form policies or develop programs, you would have to consider involving the project or the policy will affect directly, because it might be quite different from what the policy formulators may feel or experience. So I think that's one of the benefits of getting them involved. So we brought them together. We developed a communique that has an element of recommendation, recommending to the ECOWAS how they could ensure people from these three communities could participate in regional decision-making process. As much as most of the policies or interventions by ECOWAS are not really binding on member states, but they have a role of influence in policies and programs at that level. So for the purpose of this project, we made those recommendations and submitted the recommendations or the communique for the recognition and inclusion of people who use drugs, sex workers, and people who identify as LGBTQ. Remember earlier on, I said when James asked the question, and how do we attract more funding, we focus on intersectionality, right? So that was how we leveraged, that was what we leveraged on to attract the funding we have and how we could also reach out to ECOWAS. So it is expected that ECOWAS would respond to those recommendations and take the necessary action. So it means that every time we have an engagement with ECOWAS, we'll have people from this community to participate and make their input. It is all about nothing for us without us. We have to be involved because we are affected the most. We know what we need, and nobody else can know it better than we do. And that's the reason why Margaret in her presentation spoke about laws that were supposed to be protective, but I mean, they did the reverse of what they were enacted for. That is also because people who these laws affect are mostly not involved in the process. And we've developed a number of instruments in Ghana that includes the legislative instrument for harm reduction, and we had people who are recovering from drug substance use dependence were also part of it. And earlier on, somebody asked a question about how do we handle and deal with answering the questions and more making out some of the issues so that I have a holistic response to what we are discussing. So in Ghana, they've already developed a roadmap to end stigma and discrimination against people who use drugs and other communities. In that room, we had people who use drugs, people who are recovering from drugs, sex workers to make their input. And we had very interesting, and it will surprise you how one of those participants, an addict, a drug addict recovery participant said, stigma, there's what they call positive stigma, that stigma played a role in his life. In fact, the fact that he had to stop over 13 years of drug addiction was because he was stigmatized. So for the first time, we learned what positive stigmatization was. And it came from people we were advocating for, to say, don't stigmatize these people. I'll also wrap up with another example. Couple of years back, we did an intervention on sexual and gender-based violence, and the focus was on how do we reduce the level of acceptability for physical violence. It will surprise you that some of the women said, no, if we're not beaten, we don't feel loved. We don't feel like, you know, we are in charge. So we want our husbands to beat us. Whilst that may strike adversely on traditional belief, but I'm just emphasizing that nothing for us without us opens up and reveals a lot of proper intervention and sustainable intervention. So that's the position, and I want you all to know that we've submitted some of these recommendations to ECOWAS, and we're hoping to hear from them, and we hope that all three of these communities will have an inclusive decision-making opportunity at the ECOWAS. Thank you very much. Thank you, Michael.
Thank you very much, Prince, for this wonderful remarks and submission. So the floor is open for comments, questions. I know we are far behind time. We have 16 minutes to just end this webinar. But I think we just have to use 5 minutes for questions, and then speakers will give their final remarks. James, your hand is up.
Yeah, thank you very much. Thank you very much, moderator. And once more, thank you very much to the speakers and everyone who participated in this discussion. This is a very good platform for us to be able to and see how we can move our community forward. And also thank you very much to Prince Bo, Executive Director of WADPIN, for also bringing to the fore how intersectionality can be properly utilized in order to advocate for decriminalization. And that's why I speak about decriminalization as the goal for us as drug users. And I'm also happy about the achievement, working closely with ECOWAS, pushing recommendations to ECOWAS, and possibly having opportunities for communities to be able to speak directly to ECOWAS, and they themselves hearing from the community what our issues are, and also we sharing our solutions with them. So joint recommended solutions together from community to ECOWAS also is also another platform for us to amplify our voices. And I want to say thank you for WADFIN for creating that platform. I will look forward to that opportunity with ECOWAS possibly.
All right, thank you very much. Thank you very much, James. So there's actually a planned engagement that we are also hoping that ECOWAS would also join. It was supposed to have happened, but then we are still looking at a possibility of having them to join that said webinar. So the floor is still open for 1, 2, 3 comments or questions, and then I'll take the final remarks from the speakers. Then we'll call it a day. Okay, so in the absence of any questions, comments, I would like to call on the speakers. So firstly, I would like to call on the lady of the house first, and then followed by the regional coordinator for PWUD, Ahmed. So Margaret, the floor is yours, your closing remarks.
Thank you very much, Michael. I must say everything discussed here today with regards nothing about us without us, I mean, it's quite timely, and it's been an absolute pleasure to speak alongside distinguished gentlemen. I've learned a lot and I look forward to other discussions. Thank you very much.
Thank you. Thank you. Ahmed, the floor is yours for your final remarks.
Yeah, mine won't be very much. Thank you so much for organizing this call. I think it was a point of learning and exchanging learning between ourselves. One thing I will really urge us as move forward, let us genuine, let us partnership. Let us ensure that when we say nothing for us without us is not just in paper, but let us put it in practice and ensure that we achieve the 30, 60, 80 community-led response that has been there. And let us also think beyond diseases and pandemic, and also create a platform where we can be listened to other political divide. Thank you, and over to you, Michael. Yeah.
Thank you. Thank you very much. Practice, practice, practice. Thank you very much for your remarks. Samuel, your final remarks, then Prince will come, then we can call it a day.
Yeah, so thank you very much for this opportunity to share. And just like, if you may not be aware, but we in Ghana here, we are celebrating the Purple Month. So the Purple Month, we decided to use the the month of May to create awareness on mental health. And the theme for this year is mental well-being. Your voice matters. So, I mean, my final comment is that each and every one of us, those out there, those, I mean, here, our voice matters. You know, we need to, also, as we are saying that we need to empower everyone. In fact, we need to empower everybody. We need to support each other. I mean, you can't be working without even having a succession plan, you know. So we need to get people who with lived experience to bring their unique experience on board. And by so doing, we are promoting what? Inclusivity. And we're also trying to bridge the inequality gap. So I leave you with the point that please, your voice matters. Speak up and let your voice be heard. Thank you very much.
Thank you very much. Thank you. Okay, Prince, your final remarks.
Yeah, thank you very much. Thank you everyone for being on this platform for this long to support initiatives from WADPN. I want to remind you that we are hoping to host a series of webinars on this subject. I mean, it might shift a little bit. So you please look forward to that and join our next webinar. But we also look forward to your support to lobby with ECOWAS to ensure that the recommendations that have been submitted on behalf of these communities are acted upon immediately. Thank you very much, and you have a blessed day.
All right, thank you very much, Prince, for your submission. So as Prince mentioned, there's going to be another webinar in July. That one will also be looking at the progress that has been done, so like has been made so far in terms of policy, in terms of harm reduction, in terms of community engagement, in terms of championing the nothing about us without us, and also engaging ECOWAS on the policy and as a regional body to also find out some of the impact, some of the gap, or some of the interventions that can be carried out to make our advocacy project in the region a success. So in the absence of any further comments, any further questions, I would like to thank you all. My name is Michael Kumoji Tete, the Campaigns and Communications Officer for the West Africa Drug Policy Network, and I was your moderator. Thank you to our speakers, Ahmed, Samuel, Prince, and then Margaret, the lady of the house. Thank you very much for the wonderful presentation. And thank you to participants who joined, participants who have been able to stay with us right from the beginning till now. We say thank you very much for joining. Okay, McDonald, so I will be sharing the resources as well. Thank you for reminding. Okay, so all I will say is bye-bye for now, and thank you for joining.
Thank you very much. Yeah.